All right. So a very good evening to everyone. So I welcome you all to this particular series of the COVID-19 lectures. So until now, you had a great session of this particular COVID-19 on pediatrics, PSM, pharmacology, and as well as the microbiology. So now the topic of COVID-19, which I will be covering, is the general medicine perspective. And I am myself Dr. Rajesh Gubba. I am the general medicine educator on this Unacademy platform. All right. So as a part of this particular series, let me take up the general medicine perspective. So if you take the general medicine perspective, what is that I'll be covering in this particular short session, right? It's a half an hour session. So in this session, I'll be discussing the clinical features of COVID-19 and what are the various treatment options which are available for COVID-19 and what are the complications which will occur because of this particular COVID-19. And finally, we will summarize the entire topic of COVID-19. So I'll be taking the entire topic in this particular in the following manner. Now, so first of all, if you take the clinical features, before going into the clinical features, first you should know what do you mean by a word called suspected case, right? Majority of you might be listening this very common word called suspect. Now, when do we call it as a suspect? Now you see this important question. All of the following are considered as a suspect of COVID-19 except all symptomatic individuals who have undertaken international travel in the last 14 days, all symptomatic contacts of laboratory confirmed cases, all asymptomatic healthcare individuals, all hospitalized patients with severe acute respiratory illness. So, which among the following is considered as COVID-19 suspect except, the question asked is except. Right, very good. So Ravi, Vasavi and as well as Umesh, yes, every one of you are answering it correctly, very good. So the answer in this particular question is all asymptomatic healthcare personnel, they are not considered as suspected case of COVID-19. See, who are considered as a suspected case of COVID-19? The symptomatic healthcare individuals, they are considered as the suspected case of COVID-19. Now, the remaining all, they are considered as suspect. Like for example, an symptomatic individual who had an international travel in the last 14 days. That is one of the criteria for a suspect. Next, all symptomatic contacts of laboratory confirmed cases. Third, symptomatic healthcare individuals. Fourth, all hospitalized patients with severe acute respiratory illness. So these are the individuals who are considered as the suspected case of COVID-19. Or in other way around, we also have a word called asymptomatic as well. Like you see, asymptomatic individual, but if the individual is at high risk contact of a confirmed case, then also we call him as a suspected case of COVID-19. So asymptomatic direct and high risk contacts of a confirmed case is also considered as a suspect. Now, what do you mean by this word, the high risk contacts? What do you mean by this word, high risk contacts? High risk contacts are those who live in same household with a confirmed case and healthcare personnel who have examined a confirmed case. Right? Yes, Ravi Kumar, I am about to teach the same thing, and good evening for you. Right. So this is what is considered as suspect. All symptomatic individuals or asymptomatic individual who is in contact with a high risk individual. Like who is considered as high risk contact now? High risk contact include those who live in same household with a confirmed case and healthcare personnel who have examined a confirmed case. Right? Now we will move on to the next question. Now I am speaking about the word symptomatic. Now, what do you mean by the word symptomatic? Let me tell you, you take all the viruses related to your coronavirus. You take your 2019 novel coronavirus, MERS coronavirus, or SARS coronavirus. In all of them, the most common symptom is fever. Right? In all of them, the most common symptom will be fever. And followed by that, the other clinical manifestations, they include dry cough, dyspnea, diarrhea, sore throat. These are all the other symptoms of this particular coronavirus. Okay. Yes, Avinash is asking a question. Sir, asymptomatic with travel history. No, asymptomatic individual with travel history is not considered as a suspect. Right? Asymptomatic individual with travel history is not considered as a suspect. He should be a symptomatic individual to consider as suspected COVID-19 patient. Right? Next. Now, so summarizing the entire story until now, the most common symptom is fever and they will have dry cough. Now, can anyone tell me why these particular patients with the coronavirus have dry cough? Right. So, why they will have dry cough? Yes, Sai T Ram, I'll answer your question. Just give me 1 minute. Right. Yes, very good, Avinash. Right. Avinash has answered this question. So the point is that these individuals will have dry cough because it will cause interstitial lung disease, right? Or it will cause atypical pneumonia, and that is the reason why these particular coronavirus patients, they'll have dry cough. And yes, Ravi Kumar, when will URTA and LRTA occur after the infection period, right? Very good question asked by Ravi Kumar. Let me answer him. See, until 7 days, right? Until 7 days, the patient will be in a state of upper respiratory tract infection. And following this particular 7 to 10 days, right, following this particular 7 to 10 days, the individual will develop the lower respiratory tract infection, right? So until 7 days, the individual will be in a state of the upper respiratory tract infection. Yes, Ravi Kumar, is that clear? All right. Now, yes, sir, if they are not considered as suspect, why do we keep them in quarantine period? Sai Shtiram is asking a question. Now, let me tell you, the individuals keeping in quarantine is mainly to see that the individual may not be in the incubation period. Otherwise, we don't require to keep them in the quarantine. So what quarantine is advised? Home quarantine is advised, not in the quarantine centers, right? Right. Now we will move on to the next. Then who is considered as the confirmed case? Now, just now I have explained you what is a suspect. Now let me tell you what is a confirmed case. Confirmed case is that a person with laboratory confirmation of COVID-19 infection irrespective of clinical signs and symptoms. This is very, very important point, right? Whether the clinical features are present or not present. But if there is laboratory confirmation of COVID-19, then it is considered to be a confirmed case, or he or she is considered to be a confirmed case. And what is that laboratory confirmation? That is your real-time PCR, RT-PCR. Okay, so this is the one which will confirm your COVID-19 infection. Then, yes, RT-PCR is the one which will confirm. Next. Now, we will move on to the clinical features of the COVID-19 in a stepwise manner. Now, the patients of COVID-19, they are classified into, depending upon the clinical features, as mild, moderate, and as well as severe. Now, you take in these patients with the mild, what do they have? They'll have fever, right? They'll have dry cough, right? They can have sore throat, right? They can also have myalgias, right? They can also have myalgias. Then these individuals with mild COVID-19, there is no shortness of breath, right? They will not have shortness of breath in case of mild. Whereas in moderate and severe cases, these individuals, along with these manifestations, they will also have difficulty in breathing or shortness of breath. All right. Yes, Ravi Kumar is asking a question, and let me see that question. Without sign, how pulse rate will test? Now, PCR, how will be positive without symptoms? Right. Now, let me tell you, the PCR can be positive even though the individual is not symptomatic. Right. Depending upon the immune status of the individual, depending upon the tolerability of the individual of the cytokine storm, the individual might be asymptomatic, but he might be infected with the COVID-19. Right. So, like for example, okay, now just now your microbiology class has been over. Now tell me, on which day of the infection RT-PCR will become positive? In which day, after which day of your COVID-19, the RT-PCR will become positive? Yes? Can anyone answer this question? Right. So that is after, I did not get the right. So it is in between 5 to 7 days. Right. It is in between 5 to 7 days the RT-PCR will become positive. Right. So by your 5th to 7th day, the individual may be asymptomatic. Right. Yes, Ravi Kumar, this is the answer to your question. By 5th to 7th day, by the time the RT-PCR becomes positive, the individual may be asymptomatic. But we cannot consider them that he is not coronavirus patient because the symptoms are not there. The symptoms may develop gradually depending upon the immune status of the individual and depending upon the tolerability of your cytokine storm. Right? Now I'll ask you one more question. Right. Now I said you like severe illness. Now what is the difference between mild and moderate and severe? In moderate and severe, they will have shortness of breath. Whereas in mild, they will not have shortness of breath. Now what is the difference between moderate and severe illness then? What is the difference between moderate and severe illness then? Now if you take the severe illness, they should have tachypnea of respiratory rate more than 30. They should have very severe respiratory distress, and oxygen saturation at room air should be less than 90%. And even if you take the blood pressure should be, systolic blood pressure should be less than 90 systolic blood pressure. Then we call them as the severe illness. And this particular severe illness, that can be manifested in the form of ARDS, it can be manifested in the form of sepsis, or it can be manifested in the form of septic shock. In any of these particular forms, the severe illness can be manifested. Now, I'll ask you one more question. Yes. Which of the following statement is incorrect? Mild ARDS 150 to 300, that is PaO2 by FiO2. Moderate ARDS 100 to 200. Severe ARDS PaO2 by FiO2 less than 100. Fourth option, SpO2 by FiO2 less than or equal to 315 will suggest the ARDS. The question asked is, which is the incorrect statement? Yes, Praveen Kumar, good evening. Yes, which of the following statement is considered as incorrect? Right, very good, Bharti Velan. So Bharti Velan has answered this question. So the answer is A. See, mild ARDS, what should be the PaO2 by FiO2? In case of mild ARDS, the PaO2 by FiO2 should be in between 200 to 300 millimeters of mercury. Right, should be in between 200 to 300 millimeters of mercury. Right, that is what is called as mild ARDS. So the answer is A. Now, instead of, like for example, if PaO2 is not available, right, if PaO2 is not available, then you can substitute PaO2 with SpO2. But if you are taking SpO2 as a parameter, SpO2 by FiO2 should be less than 315. That will suggest the ARDS. That is the correct statement. So which is the incorrect statement here? The first option. So in case of mild ARDS, the PaO2 by FiO2 will be 200 to 300. In moderate ARDS, 100 to 200. Whereas in severe ARDS, it is less than or equal to 100 millimeters of mercury. And if PaO2 is not available, then we need to take SpO2. And if you take SpO2 into consideration, SpO2 by FiO2 should be less than or equal to 315. That will suggest the ARDS. That is a correct statement, right? Next. Now, coming to the management protocol, like if the patient is having ARDS, like for suppose, once you diagnose that the patient is having ARDS, then you should immediately start the oxygen therapy with face mask as well as the reservoir bag of 10 to 15 liters per minute, right? So you need to start with high flow oxygen with bag and mask, reservoir bag. Like with this reservoir bag of 10 to 15 liters per minute, the patient is not responding, he is desaturating. Then what you do is you need to connect the patient to high flow nasal catheter oxygenation or non-invasive mechanical ventilation. That is when the patient is not responding to your reservoir bag. Then in spite of that, right, in spite of your high flow nasal catheter oxygenation or non-invasive mechanical ventilation, the patient is not responding. That means within 1 to 2 hours, the patient, you watch for 1 to 2 hours. Within this 1 to 2 hours, the patient is desaturating. In such case, you need to intubate the patient. You have to put the patient on invasive mechanical ventilation. So this is a stepwise therapy what you need to follow in an ARDS patient. First, high flow oxygen with reservoir bag. Not responding, non-invasive ventilation and high flow nasal catheter oxygenation. Not responding, then you put the patient on the mechanical ventilator. Right now, the next important point is that, like, what are the ventilatory settings? Very good that you have put the patient on ventilator. What are the ventilatory settings? There should be a low tidal volume. How much should be the tidal volume? That is in between 4 to 8 ml per kg. And there should be a lower inspiratory pressures. That is plateau pressure of less than 30 centimeters of water. And you take the PEEP. Yes, very good, Sai. So it should be a very higher PEEP, right? It should be a very higher PEEP. And followed by that, the patient should be put on prone ventilation for more than 12 hours per day is very much recommended. So these are the ventilatory settings that you need to keep the patient with severe ARDS, right? Low tidal volume, lower inspiratory pressure, that is plateau pressure of less than 30 centimeters of water. Very higher PEEP has to be maintained. Next, the patient has to be put on the prone position for more than 12 hours per day is very much recommended. Now, see, many of you have the questions related to this particular prone ventilation. What is the purpose of keeping the patient in prone position? I just ask you a question related to that. Okay. Which is the incorrect purpose of the prone position? Yes, Ravi Kumar is asking a question. Sir, mild ARDS, PaO2 by FiO2 should be 200 to 300. Mild ARDS, yeah, the correct value is more than 200 to less than 300. Right, more than 200 and less than 300. Yes, Ravi Kumar, is that clear? Right. So which is incorrect purpose of the prone position? To improve oxygenation, to improve respiratory mechanics, to homogenize the pleural pressure gradient, the alveolar inflation and the ventilation distribution. And fourth option, extreme care is not necessary when this maneuver is performed. Right, very good. So some of you are answering this correctly. So the answer is extreme care is necessary when this particular maneuver is performed. Now, let me tell you what are the advantages of this particular prone position. These three are correct. Right, these three are correct. What are those? Number one, prone position will improve the oxygenation of the individual. Second, it will also improve the respiratory mechanics within the individual. Third, it also helps in homogenizing the pleural pressure gradient. Fourth, it will reduce the amount of the atelectatic regions. Fifth, it will facilitate the drainage of secretions. And finally, to reduce the ventilator associated lung injury. See, these are the reasons why you need to put the patient in prone position for nearly around 12 hours per day, right? And that will definitely improve the oxygen. The oxygenation will improve of almost 80 to 90%, right? 80 to 90%. And it will also reduce the dead space. That is what is nothing but you are improving the respiratory mechanics, right? Next, we will move on to the next question, right? This is a very important question. In a suspected mild case of COVID-19, which of the following drug can be given? Hydroxychloroquine, remdesivir, oseltamivir, lopinavir. In a suspected mild case of COVID-19, which of the following drug can be given? Right. So I was expecting from all of you as the hydroxychloroquine, right? But the answer, no, yes, only Ritesh Srivastava has answered this question. Very good, Ritesh Srivastava. The answer is the oseltamivir, and even Pooja has also answered. Very good, Pooja. Now you read the question properly. In a suspected mild case of COVID-19, which of the following drug can be given? Now I will just show you a flow chart which is being laid by the AIIMS hospital. Now you see this particular protocol which is being managed by the AIIMS New Delhi hospital, and whatever the questions you get, you can claim this as a reference, right? You can claim this as a reference because all of you are about to write the central exams of the Indian origin. So this is the standard treatment which is being followed all over India. What is that? Like for example, you have a COVID-19 suspected patient. Now what is a suspect? Already I have explained you what do you mean by a suspect. Like for example, you consider it as a mild case. What is a mild case? They'll have fever, dry cough, nasal discharge, but no shortness of breath. Okay. Now, so when the individual is suspected to be mild, what you need to do is you need to start the treatment with oseltamivir 75 milligrams BD, right? Yeah. So I'll just explain. For some of you, yes, I do understand it is not visible, right? I'll try to explain. 1 second. I cannot maximize this also. Right, I'll try to explain, don't worry about that. So in my case, what you need to start is you need to start tap oseltamivir 75 milligrams BD mainly in those individuals who are at high risk of influenza. Then along with that, you need to start antibiotics, azithromycin plus amoxicillin, and even paracetamol also has to be given depending upon your SOS basis. So this is in case of the treatment in case of mild case, suspected case of COVID-19. Then, okay, you test the patient. For example, if the test is negative, then symptomatic management. For example, if the test is considered to be positive, then don't admit the patient, not required, because our hospitals are already full, right? The hospitals which are considered as COVID-19 hospitals are already full. If it is a mild case, not required for admission, you just advise him the home isolation. Until when? Until 2 tests are negative which are at least 24 hours apart. He should be under home isolation. But then which group of individuals you require them for admission? You require admission for high risk individuals. Who are considered as high risk individuals? Elderly patients, diabetic patients, hypertensive patients, patients with congestive heart failure, patients with renal failure, patients with liver failure. These are considered as the high risk patients. So high risk patients you admit. Otherwise, if the individual is stable, you advise him for home isolation. But the patient, now he is considered tested to be positive. Now what is the treatment he has to take? Don't jump and start hydroxychloroquine. What according to your AIMS protocol tells is you just give only paracetamol and symptomatic treatment. You just give only paracetamol if he is a mild case. You understand that? Now, for example, what is the treatment for moderate to severe case? I'll explain you for that. So, I'll revise the mild case. What is a mild case? Mild suspected case, fever, dry cough, diarrhea, myalgia, fatigue, but no shortness of breath, no dyspnea. Before testing, you start symptomatic management for fever, paracetamol. In high-risk cases of influenza, start oseltamivir and antibiotics like amoxicillin and azithromycin. And if test is negative, continue the symptomatic treatment. If the test is positive, advise him the home isolation until the two tests at least 24 hours apart they are negative. And in high-risk individuals, you admit the patient. And what is the treatment the individual has to take? Just paracetamol. And treatment, yes, antitussives are also recommended. That is in case of a mild case, right? Yes, for mild cases, antitussives can be recommended. Now, you see the next question. A 46-year male patient with severe COVID-19 was started on a combination of medication, after which he developed vertigo, nausea, vomiting, and diarrhea. What is the suspected combination of the drugs he might be started with? Hydroxychloroquine and remdesivir, hydroxychloroquine and lopinavir. Third option, hydroxychloroquine and paracetamol, plasma therapy and paracetamol. Right, very good. So yes, Avinash and Yashram has answered, very good. So the answer is the hydroxychloroquine and as well as lopinavir combination. Always remember this particular hydroxychloroquine and lopinavir combination should not be given. Right, hydroxychloroquine and lopinavir combination should not be given. This is a very, very important point. Now, see, until now what we have discussed the treatment of mild COVID-19. Now let me discuss the treatment of moderate and as well as severe COVID-19. Right. Now what is the difference? I have already discussed. Mild means no dyspnea, whereas in moderate to severe cases, you will have dyspnea. And apart from dyspnea, when do you consider that the patient to be moderate to severe? The individual is having tachypnea, that is respiratory rate more than 24. Room air oxygen saturation is less than 94%. The individual is drowsy and confused, and systolic blood pressure is less than 90. These are considered as severe cases. I'll repeat again. Respiratory rate more than 24. Saturation less than 94% room air. Patient is confused or drowsy. And last one, systolic blood pressure less than 90 millimeters of mercury. These are the parameters you need to consider for severe cases, right? Now, you have tested the patient and the test has come positive, right? You have tested the patient as test has come positive. Now, first and foremost, what is the line of treatment you have to start with? Immediately connect the patient to oxygen. And what should be your goal of oxygen when you have connected the patient to the oxygen? The saturation should be more than 94%. Right? The saturation should be more than 94%. Then the other drugs like antipyretics for fever, antitussives for cough, and meter dose inhalers, they are preferred over the nebulization. And the drugs which are preferred are hydroxychloroquine. And how much of the hydroxychloroquine is recommended? Hydroxychloroquine 400 milligrams on day 1. Followed by that 200 milligrams for 5 days. I'll repeat again. Hydroxychloroquine 400 milligrams on day 1. Followed by that 200 milligrams twice daily for 5 days. That is the dosage of your hydroxychloroquine. What are the other drugs? The other drugs are lopinavir or ritonavir. 200 milligrams twice daily has to be given. But whenever you are giving hydroxychloroquine, don't give this particular lopinavir ritonavir combination, because this lopinavir ritonavir combination, that is causing this particular vertigo, nausea, vomiting and diarrhea. They have drug-drug interaction. So this combination should not be given. Right? Next. What about the story of corticosteroids? Let me tell you that corticosteroids should not be given because they are immunosuppressive agents, right? That will further reduce the immunity of the individual. So that is the reason why you should not give corticosteroids. So in moderate to severe patients, if the test is positive, what is the line of management? Oxygen supplementation, and you have to maintain the saturation more than 94%. Meter dose inhalers are preferred over the nebulization. Hydroxychloroquine has to be given, or lopinavir ritonavir combination drugs has to be given, right? But don't combine both, right? Okay, you have started all these, excellent, superb, but the patient is not responding. The patient has developed respiratory failure. The patient has developed hypotension. The patient is having worsening of the mental status, and the patient has developed multi-organ dysfunction. Immediately, you have to shift the patient to ICU. Immediately, if the patient is worsening in your ward, shift the patient to ICU. And what is that you will do in ICU? In the ICU, immediately connect the patient to non-invasive ventilator. Already when the patient was in the ward, he is on that high flow oxygen, but he is not responding. Now you shift the patient to ICU and connect the patient to your NIV, non-invasive ventilator, right? And ventilator management, even with your NIV, okay, you wait on NIV for 1 hour. With NIV, if the patient is maintaining the saturation, well and good. But even with non-invasive ventilator, if the patient is desaturating, immediately connect the patient to mechanical ventilator. And let me tell you the contraindications of NIV. This is a very, very important point. Please listen carefully. Contraindications of NIV. Hemodynamically unstable patients, don't connect the patient to NIV. Hemodynamically unstable, don't connect the patient to NIV. Second, the patient is in state of altered sensorium, don't connect the patient on NIV, directly put the patient on mechanical ventilator, right? Now ventilator settings already have explained, right? What should be the tidal volume? PEEP should be very high, tidal volume should be in between 4 to 6 ml, all that I have discussed earlier only. What should be the ventilatory settings? And conservative fluid management. Remember, fluids you should not overload, because already the patient is in a state of non-cardiogenic pulmonary edema, that is your ARDS. So you should not load the patient with fluid. If required, you put the patient on vasopressor therapy, but don't load the patient on with fluids. Okay, so vasopressor therapy is given for maintaining the blood pressure, and then closed suction is very much recommended, and as well as the HME filters, that heat and moisturizer filters, that will prevent the spread of that COVID-19 in the surrounding areas, right? And the other thing is prone position. What is the advantage of the prone position? I have already explained. Now, very good, you have done superbly job with mechanical ventilator, but the patient is still not responding to your mechanical ventilator. Then connect the patient to your ECMO. What is ECMO? Extracorporeal mechanical oxygenation is what is called as ECMO. Now what does this ECMO does? ECMO will keep your lungs at a resting state, and the function of the lungs will be done by your ECMO. That is what is your ECMO, right? So I'll just repeat again in 1 minute. If in case of moderate to severe cases, what you should do. When do you consider moderate to severe case of COVID-19? Tachypnea more than 24, desaturation less than 94% in room air, confusion and disoriented, systolic blood pressure less than 90. And the test is considered to be positive now. Then what you should do? Antipyretics, meter dose inhalers, hydroxychloroquine, or lopinavir ritonavir combination. Don't club them, right? Don't combine them. Drug-drug interactions are there. Corticosteroids should not be given. Not responding, shift the patient to ICU, connect the patient to NIV. And if the individual is hemodynamically unstable, if the individual is in altered sensorium, don't put the patient on NIV, directly put the patient on mechanical ventilator, right? And what are the settings in mechanical ventilator? Already have explained, right? And prone position has to be maintained for at least 12 hours per day. And what is the advantages of the prone position? I have explained. Not responding to mechanical ventilator, then put the patient on ECMO, that is extracorporeal mechanical oxygenation, right? Next. Now finally, when will you discharge now? How many days you will put the patient? When you have to discharge the patient is once the patient is stabilized, there is clinical improvement, radiological improvement, your RT-PCR is negative, minimum 2 samples should be negative with a gap of 24 hours. That means today at 8 p.m. you have done RT-PCR, it has come negative. And again tomorrow at 8 p.m. you do RT-PCR, it is negative. That is considered as a negative case. So clinical improvement should be there, radiological improvement should be there, and your RT-PCR also should be negative. That is the point when you can discharge the patient happily with a smiling face, right? Next. Now, you see, this is one of a very interesting question. A 52-year male with COVID-19 on treatment with hydroxychloroquine, and he had a sudden onset unresponsiveness, and you are the attending doctor. What will you advise first? Urgent CT scan, arterial blood gas analysis, ECG, chest x-ray. What is that you will advise first? Right. So, yes. So, Shadab Alam has answered this question and Bhuvana has answered. Okay, many of you are answering these questions. Very good. So, you have to do ECG. Why? Why you want to do ECG? Why you want to do ECG? See, the patient is sudden onset unresponsiveness. Sudden onset unresponsiveness. Why? Because, right, why? Because, very good. So this hydroxychloroquine is a culprit drug, and this is the one which can cause the QT prolongation, right? This is the drug which can cause your QT prolongation. So the same ECG I have put here. So if you calculate the QT interval here, the patient is having a QT interval of 550 milliseconds in this ECG. So now what is the disadvantage? Okay, if there is a QT prolongation, what is the problem which is going to occur? Let me tell you that if the patient develops QT prolongation, that individual may land up in the Torsades de Pointes. Right? That individual may land up in Torsades de Pointes. So what is Torsades de Pointes? Torsades de Pointes is a polymorphic ventricular tachycardia. Right, it's a polymorphic ventricular tachycardia. Okay, now can anyone tell me what is the drug of choice here? What is the drug of choice? Yes, Santanam, you can consider hydroxychloroquine induced hypoglycemia also, but in my options blood glucose monitoring is not there. I have given you only 4 options: chest x-ray, CT scan, ABG, and as well as ECG. Right, so the drug of choice here is the magnesium sulfate. 1 gram of magnesium sulfate has to be given. Right, 1 gram of, not amiodarone, it is magnesium sulfate which is considered as the drug of choice for your Torsades de Pointes. So to revise again in 1 minute, so the patient is having sudden onset unresponsiveness on hydroxychloroquine. Think of QT prolongation. Do an immediate ECG. If the ECG is showing QT prolongation, you have to suspect that the individual might have landed in Torsades de Pointes, which is called polymorphic ventricular tachycardia, and for that you need to give 1 gram of magnesium sulfate. That is considered as the drug of choice. Okay, next. Now, okay, so I think just now pharmacology has been over for you, but anyhow, I just want to discuss what are the various drugs which are available for the COVID-19. Number 1, we have the plasma therapy, right? What are we doing now? those patients who have been treated with COVID-19, we are taking their plasma, and that particular individual's plasma we are infusing in those individual who is suffering with COVID-19. Why? What is the mechanism of action? Right? What is the mechanism of action? The mechanism of action is that these particular antibodies, they will prevent this particular coronavirus to bind with the ACE2 receptors. See, how does the coronavirus enter into your human cell? That might have discussed with you in microbiology. That is through your ACE2 receptors. So your antibodies that will block that particular ACE2 receptors, and that will prevent the entry of your coronavirus. Then you take the other drug, that is camostate mesylate. What is the mechanism of action of this camostate mesylate? That will block your TMPR SS2 channel. What is this TMPR SS2 channel? That is also the one which helps in the entry of this particular coronavirus. That is the second drug. Next, lopinavir and ritonavir. What are actually these group of drugs? Your lopinavir and ritonavir, these are your protease inhibitors. Where do we give actually? We give them in the treatment of HIV. They are the drugs which will cause proteolysis. They are your protease inhibitors. So they will cause proteolysis, and thereby formation of the nucleic acid material will not occur once you give this particular lopinavir and ritonavir. That is the mechanism of action of lopinavir and ritonavir. Next, many of us are very much aware of this particular hydroxychloroquine. What is the mechanism of action of this hydroxychloroquine? Hydroxychloroquine, it will prevent the endocytosis. Right? Hydroxychloroquine will prevent the endocytosis. Then we have another drug that is called remdesivir. What this particular remdesivir will do? Remdesivir will inhibit the RNA dependent, the RNA polymerase, and thereby the nucleic acid material formation does not occur properly. So these are the mechanism of actions at different levels of the virus. I'll repeat again in 1 minute. Monoclonal antibodies, they will prevent the entry by blocking ACE2 receptors. Camostate mesylate, they will block your TMPR SS2 channel. Hydroxychloroquine, they will prevent endocytosis of the coronavirus into the human cell. Lopinavir and ritonavir, they will prevent or they will cause the proteolysis. Right? They will break the polypeptide chain of the coronavirus. Remdesivir, it will inhibit the RNA dependent RNA polymerase, and thereby the nucleic acid material formation does not occur. So that is about the various drugs which are given in the treatment of the coronavirus, right? Next. Now, this is one of the very important questions. Which is the preferred sample to be sent for coronavirus 19 testing, COVID-19 testing? Throat and nasal swab, nasopharyngeal swab, bronchoalveolar lavage, endotracheal aspirate. What is that you want to send? Very good. So Kritika has answered first, and followed by that many of you are answering this. Very good. So the preferred sample is your throat and nasal swab. Right? It is not bronchoalveolar lavage, Avinash. It is not BAL. It is your throat and nasal swab is preferred sample. And in which group of individuals we send this nasopharyngeal swab, BAL and endotracheal aspirate? Those patients who are on mechanical ventilator, right? Those patients who are on mechanical ventilator, right? Whoever on mechanical ventilator, we have to send nasopharyngeal swab, bronchoalveolar lavage, and as well as the endotracheal aspirate. And where is this guidelines from? The guidelines is from AIMS. Right? This particular guidelines has been led by AIMS hospital. Right? So the preferred sample is the throat and as well as the nasal swab. Right? Next. Now, and all that particular samples, whichever has been taken, should be put in the viral transport medium and should be transported on the ice. Right? Should be transported on the ice. Okay. And very important point, a trained healthcare professional has to wear appropriate PPE while taking the sample with latex-free purple nitrile gloves, right? With latex-free purple nitrile gloves. This is a very important multiple choice question, right? Take this point. Next point. And whenever you are taking the nasopharyngeal swab, you tilt the patient to 70 degrees and rub the swab both over the tonsillar pillars and posterior oropharynx and avoid touching the nose, teeth and as well as gums. Right? Next point. Use only synthetic fiber swabs with plastic shaft. Do not use calcium alginate swabs or swabs with wooden shafts. Right? So I'll repeat this one point in 1 minute. So the preferred sample is throat and nasal swab. And whenever you are taking once you have taken the sample, put that particular sample over the viral transport medium and transport on the ice. And whenever you are taking the sample, use latex-free purple nitrile gloves. And you have to tilt the patient's head up to 70 degrees and rub over the nose or the nostril, the tonsillar pillar and posterior oropharynx. Avoid touching the tongue, teeth and gums. And you should use only synthetic fiber swabs with plastic shafts. Do not use calcium alginate swabs, right? Then coming to the complications of the final thing, complications of your COVID-19. There was one study which was done in Italy. What has been found was these patients with the COVID-19, there is high incidence of renal failure. Right? There is high incidence of renal failure that has been found in one of the study done in Italy. Second, cardiac complications of COVID-19. Number 1, myocarditis. Number 2, ischemic heart diseases. Number 3, arrhythmias. Right? Number 3, arrhythmias. So these are the cardiac complications of your COVID-19. And finally, summarizing the things now, what all we have learned? What is a suspected case? Right? I have given you 4 criteria. Then what is a confirmed case? Then followed by that, this particular table is very, very important for the management. Mild case, how do we manage? Moderate case, how do we manage? Severe case, how do we manage? And what are the ventilatory settings? When we should discharge the patient? And drug combinations are also very, very important. And adverse effects of your hydroxychloroquine. So this is the summary of the today's session. Right? So with this, I'm just winding off my session on the COVID-19 general medicine perspective. And for further notifications, please follow me on Unacademy. And you can follow and ask me the doubts related to general medicine on my Telegram channel, that is Medicine Made Easy. And you can also follow me on my Facebook channel, that is Medicine Made Easy. So thank you very much, and I wish you all the best for your upcoming exams. And please be careful when you are going out, roaming out, when you are attending the patients, coming back home, you please follow all the personal protective care, what you have to do. Stay healthy and write your exams with great confidence, and I wish you all the best. Thank you very much.